Good morning and welcome to the New York State Center of Excellence for Alzheimer's Disease educational session. We will review a few slides with explanation, and if you have any questions, please contact our center. So today we will be talking about Alzheimer's disease and mild cognitive impairment, and the first session is about how we make the diagnosis. So the differential diagnosis of dementia changes over time. In the very early stages of Alzheimer's disease, we have to differentiate it from normal aging and mild cognitive impairment, which appears to be a neuropsychological continuum. Later in the course of the disease, we have to differentiate Alzheimer's disease from the various other types of dementias, as in moderate stages, a lot of these dementias will look very similar, a globally impaired individual needing a lot of care. Unfortunately, we have limited tools. There's no specific diagnostic test except pathology, which is not indicated in at this stage because we don't really have any interventions that are specific. So the best we can do in a living individual is a probabilistic diagnosis. So what other types of dementias are there that we need to differentiate? And this is not an exhaustive list, just something to think about. The most common form of dementia is Alzheimer's disease. We have to differentiate it from frontotemporal dementia, vascular dementia, dementia with Lewy bodies, some of the Parkinson-related dementias, which are the Parkinson plus syndrome, such as cortico-basal ganglionic degeneration, progressive supranuclear palsy, multiple system atrophy, or frontotemporal dementia with Parkinsonism linked to chromosome 17, for which actually we know the genetic mutation, what causes it. We have to rule out normal pressure hydrocephalus because it requires a different type of treatment approach. We have to think about CJD or Creutzfeldt-Jakob disease. And then there's a whole list of rapidly progressive dementias. If you come across a rapidly progressive dementia that occurred over a few weeks, then that person actually needs hospitalization and an intensive workup. So what happens in Alzheimer's disease? This is a brain at autopsy of a normal individual at the same age as this person who had Alzheimer's disease. And you can appreciate the significant cortical volume loss, the thinning of the cortex, of the gray matter, enlarged CSF spaces, both extraaxial and intraaxial. You can appreciate the hippocampus here, which is nice and full, and in Alzheimer's disease, the hippocampus has marked atrophy. If you look at this picture, the ventricles appear ballooned. And that is because the shrinkage of the brain from inside and from outside will enlarge the spaces inside. So sometimes this is misread as normal pressure hydrocephalus. If there's no discrepancy between the extraaxial and the intraaxial enlargement of the CSF spaces, then it really just suggests atrophy. And what we see pathologically, we see amyloid plaques, which are extracellular depositions of various proteins, including the amyloid beta protein. And we see neurofibrillary tangles, which are neurons which undergo neurodegeneration. Also, we can appreciate amyloid angiopathy when amyloid is deposited in the blood vessels, and that increases the risk of bleed. So how do we make the diagnosis? As a field, Alzheimer's disease came up with diagnostic criteria. And this is because we really don't have a specific test. For blood pressure, it's very easy. You take the blood pressure cuff, you measure it, you treat the person, you measure it again, and you know what is your outcome. Here you have to put pieces of a puzzle together, exclude certain things, and prove certain things to make really the diagnosis. So for probable Alzheimer's disease, the NINCDS ADRDA criteria requires the following: deficits in 2 or more domains of cognition. And the cognitive domains are memory, language, perceptual skills, attention, constructive abilities, orientation, problem solving, and functional abilities. And to screen for deficits in these domains, we can use clinical symptoms, cognitive screening tests, and neuropsychological testing. The more advanced the disease, the easier it is to find at least 2 domains and make the diagnosis of Alzheimer's disease. The real challenge comes to differentiate normal aging from mild cognitive impairment and then amnestic mild cognitive impairment from very early AD. And these all have different treatment approaches, so we really need to make that diagnosis. So the clinical symptoms, usually the red flag in Alzheimer's disease is a memory problem. And the memory problem is an episodic memory problem, which means that they cannot retain newly acquired information. So when you tell them, we are going for dinner tonight with the Joneses, an hour later, the person might ask, are we doing anything tonight? Did you say something that we are going out? And they forgot that this conversation happened or exactly what was the content of the conversation. As the episodic memory problem progresses, these intervals of repeated questions become shorter and shorter. So the red flag is not that I forgot to turn off my coffee maker, because that happens to all of us. The red flag is if somebody is repeating the same conversations, the same stories, and they do it in a way that they are not aware that they have already said that story. So that's a clinical symptom. How can we measure it? Now, the best way to measure episodic memory impairment is to have somebody register words or stories and then ask them what they remember 20 minutes later. Now, this is often prohibitive in a primary care setting. You don't have 20 minutes to do just assessment of one single domain. So we have some tools, and we have some screening tools like the mini-cog test, or what we use in the Alzheimer's Center is a paired associate testing. We have 4 pairs of words, more and more difficult to remember why they are paired because it's less and less logical. And we do 2 learning trials. So the learning is actually also getting impaired with the advancement of the episodic memory impairment. So the first signal comes from the delayed recall, but the second signal comes from the learning curve. So that's something that you can use. If still in doubt, if you can't really measure it, but the history is suggestive of a memory disorder, then neuropsychological testing is the test of choice, where we have correction for age and education, and we have exact measures. We have also cutoffs as -2 Z-score for defect and -1.5 for impairment, and that classifies a person with dementia or mild cognitive impairment. Now, if you look at the list of all the others, language, perceptual skills, attention, constructive abilities, orientation, problem solving, or functional abilities, this is a very long list for a primary care visit. It's a very long list even for a neurological exam and visit. So if somebody is advanced enough and they have clear-cut problems of word-finding difficulties, decreased communication, then you have it, but that's usually moderate stage dementia. So for the early stages, to do a fairly good screen for impairments of all of these, you really need a formal neuropsychological evaluation. And you don't have to do 6 to 8 hours. A 2.5 hour battery will answer these questions. The most common things to go after memory and give you the second domain in Alzheimer's disease is generative fluency, coming up with words within a category. For example, can you tell me as many words as you can think of from the supermarket? So a normal person will remember the supermarket aisle and start to list all those things that you can see in the supermarket. Person with Alzheimer's disease has a hard time visualizing that or thinking of it, and they will have much less generative fluency. The other domain that frequently goes as second is the trail making test B, which is a more complex task. You have to connect A1, B2, and they have difficulty understanding that. Functional abilities. There are very good questionnaires, validated questionnaires called the physical self-maintenance and instrumental activities of daily living. These are publicly available, and the caregiver can fill it out while you are working with the patient and trying to work the patient out. I would like to point out that functional abilities can be your second domain. So if somebody's memory impairment is only memory impairment and all the other neuropsychological measures are fine, if they cannot function, if they need help with banking, if they need help with groceries because the memory problem is so severe, then they qualify for Alzheimer's disease. That can be the second domain. The second thing that has to be present is a decline of memory and other cognitive functions over time. And we usually expect at least a 6 month observation period for the decline. We have to have preserved consciousness. And this is pretty much a no-brainer, but sometimes, people can be not perfect consciousness when they even look normal. So for example, if an elderly person has a UTI, you don't want to do the formal neuropsych testing at that point because they could be impaired from the UTI. And you want to test them when they are at their best. So you want to eliminate all infections. It's not good to test them in the hospital, obviously. You want to discharge them, get them in their best state, and do a follow-up visit to fully assess the memory problem and the cognitive deficits. You can suspect in the hospital setting, but you should not make the diagnosis in the hospital setting. Next one is onset between ages 40 and 90. This is a little bit outdated. Episodic memory impairment is never normal. Alzheimer's disease is never normal. So we actually do diagnose patients over 90, and as life is getting longer and longer, there are very good 90-year-olds who actually just started dating in one of the nursing homes. So, you want to give them the best. The treatment for Alzheimer's does not prolong life. It prolongs the quality of life because it keeps them as good as they are for as long as we can. So you want to treat even a 90-year-old. And unfortunately, we have cases under 40, and those are usually the autosomal dominant forms of Alzheimer's disease associated with mutations in amyloid precursor protein, presenilin 1 or presenilin 2. These are very strong family histories. So if you have 3 consecutive generations with Alzheimer's disease before the age at onset of 60, you need to think about one of these genes. The inheritance pattern is autosomal dominant, so the transmission is about 50% chance, and there are genetic tests available, and people can decide that they want to be tested. People can decide that they want to test pregnancies before they have children. Another group with the genetic component and close to 40 with age at onset of Alzheimer's disease is patients with Down syndrome. Down syndrome has a triplication of the amyloid precursor protein because it is coded on chromosome 21, and they have 3 chromosome 21s, and because of that they have a lifelong overproduction of amyloid beta. So all Down syndrome patients will have Alzheimer's disease at a certain time point, and what we see in the clinic, it usually occurs between 40 and 50 when they start to decline with function. Now, you also have to rule out that other systemic or brain diseases are not present, and the American Academy of Neurology guidelines actually has neuroimaging in the workup. So at the initial workup, and you really don't have to repeat it, but at the initial workup, you need to do neuroimaging because strokes, strategically placed strokes, strategically placed meningiomas, which are benign tumors, can present with symptoms that are suggestive of Alzheimer's disease. They have very different treatment, and they have very different prognosis because those tend to be non-progressive. And for the correctable causes and modifiable risk factors, we usually do a laboratory screen. Vascular risk factors are the most associated with Alzheimer's disease and dementia. It's probably not related to developing Alzheimer's, but it is related to earlier onset and more rapid progression. So you want to fix those. And the vascular risk factors are hypertension, diabetes, smoking, hypercholesterolemia. So you do labs for these, screening labs. We also check homocysteine, ESR, because in older people, sometimes medical illnesses, such as monoclonal gammopathies can present just as a pure memory disorder. So at the beginning, it's worthwhile to screen. Also, infections need to be considered, such as syphilis and HIV, depending upon your patient population. For correctable causes are B12 deficiency, and we often check a methylmalonic acid with B12 because low normal B12 could still be insufficient for the body, and then you have to supplement. Thyroid function is very important to screen for, as again in older people it may not have all the other symptoms of hypothyroidism. So epidemiology, you will see it because it's very common, and the incidence doubles every 5 years over the age of 65. This figure here, I just would like to point out that even with small steps, we can make a huge difference at the public health level. So the blue line is the predicted prevalence of Alzheimer's disease from 1997. This paper was written in 1997 and based on incidence rate, prevalence rate at that time, and population and longevity predictions. It was calculated that Alzheimer's disease will be growing about at this pace as the navy line here. Now, if we find something, some intervention that delays onset by just 2 years, you have a 20% reduction of people with Alzheimer's disease by year 2047, because this affects the older population. So there are the reasons to die, and they may never develop Alzheimer's disease. If you find an intervention that's going to delay onset by 5 years, then you cut the public health burden by half by the year 2047. So really, early diagnosis, early treatment, delayed onset, delayed conversion to Alzheimer's from the amnestic MCI stage are very important factors at the public health level. So in the context of normal aging, what is going to help you to differentiate normal aging from Alzheimer's disease or amnestic MCI related moving towards Alzheimer's disease? Meta-analysis of cognitive impairment prior to the diagnosis of Alzheimer's disease showed that there's a difference in global functioning, episodic memory, perceptual speed, and executive functioning in people who are going to develop Alzheimer's disease. Now, these studies have some MCI contamination in them because MCI really became a diagnosis only about 10 years ago when Ron Peterson from Mayo Clinic came up with this idea that there's something that has to happen between normal and Alzheimer's disease. So this is probably a little bit contaminated, and it's still undergoing research exactly what is normal for aging. We think that getting slower is normal, learning slower is normal, rapidly forgetting is never normal. So if you have the rapid forgetting, then you need to take that seriously. So mild cognitive impairment by Peterson criteria. If you look at this list, cognitive complaint, usually memory. You want also an informant to confirm that. Cognitive impairment, usually memory for age and education with a neuropsych testing Z-score of minus 1.5 or below. Now, this itself implies that you cannot make the diagnosis of mild cognitive impairment without performing formal neuropsychological testing, because your sensitivity and specificity for the clinical symptoms is very low. And you cannot correct for age and education. Your clinical symptoms cannot be corrected. So really, if you suspect that somebody has amnestic mild cognitive impairment, you really have to get neuropsych testing and measure it. People have to have normal general cognitive testing, so the neuropsych will also give you that information that all the other cognitive domains are normal. They have to have larger preserved activities of daily living. A little help with banking would be okay, but if you really have to go there every single day, make sure that they eat, that's not enough. That's the second domain. And you as a physician have to say that they are not demented. So this is actually a very subjective assessment, whether you decide that somebody is demented or not demented. So I think that you cannot really make the amnestic mild cognitive impairment diagnosis with reasonable certainty without formal neuropsychological testing. You can suspect it, but you overdiagnose and underdiagnose if you just rely on your clinical assessment skills. So we have various types of mild cognitive impairment, and when the neuropsych testing comes back, you might see various patterns. So here you see amnestic and non-amnestic. Amnestic means that memory is affected, non-amnestic that memory is actually preserved. It can be single domain, which means memory only, or multi-domain when it's memory and an additional domain. However, it's not in the defective range. That's how it's differentiated from Alzheimer's. So these people will not have minus 2 Z-scores on the neuropsych testing, just minus 1.5 Z-scores. Now, the non-amnestic can again be single domain and multi-domain. And based on your classification of the MCI, you can think about differential diagnosis between neurodegenerative, vascular, psychiatric, and medical conditions. So for the single domain amnestic, the most common cause is a neurodegenerative cause, which is Alzheimer's pathology, but depression can show this type of presentation. Now, the difference between a memory disorder associated with Alzheimer's and memory disorder of depression is, and it is included in our neuropsych battery, is recognition. So a depressed person, you give them the list of words and they cannot recall all of them or not enough of them. But if you give them the list, was this one among those words, or was this word among those words, then they will recognize which one was on it and which one was not on it. So they don't have difficulty of coding and storing this memory, but they have difficulty with recalling this memory because they are depressed, they have no initiative. Okay, so the Alzheimer patient cannot store it. So it's not gonna help no matter what you do, because it's not stored, you cannot help them recall it. However, the depressed person can store it, just does not have the strength to recall it. So if you help them with a list or give them options, they will be able to recall it. Multi-domain, again, Alzheimer's and depression. This is probably a little bit more advanced MCI. And we have vascular dementia here. And if you look at here, multi-domain, vascular dementia is always in the multi-domain category. And why is that? Because vascular dementia will be affected by the cerebral vasculature. And the cerebral vasculature has multiple fibers and circuitries involved in a single vascular territory, while neurodegenerative disease actually follows a circuitry. And then for the non-amnestic, you have frontotemporal dementia or diffuse Lewy body disease. DLB usually has visuospatial, frontotemporal dementia, executive function, or language. Now, diffuse Lewy body disease is actually very interesting because pure diffuse Lewy body disease is actually very rare. It's about 20%. 80% of LBD will have some Alzheimer component, and we call it the Lewy body variant of Alzheimer's. They have also a memory problem besides the visuospatial, and they have dual pathology. And there's some links which is actually now being investigated. What is the link between amyloid plaques and Lewy bodies in the brain? So what does it mean? People who have mild cognitive impairment have a risk of conversion to Alzheimer's disease, and it's between 1 to 25%, which is a really big range if you think about it, 1 in 100 or 1 in 4. However, if you look at just the memory amnestic MCI, so the amnestic mild cognitive impairment, then the risk of conversion is approximately 25% per year. So if you diagnose somebody, a firm diagnosis of amnestic mild cognitive impairment, 25%, 1 in 4 will convert to Alzheimer's within the first year. These people are the targets now for new interventions because we wanted reversal of Alzheimer's is not going to happen. It's very unlikely. However, disease modification and stopping the disease before it fully develops will happen. So amnestic MCI is the first time when you have symptoms, so you can actually enrich your clinical trial for people who have symptoms, but they are still in very, very good shape. So it's really worthwhile to stop the disease at that stage and not let it progress. So these people are becoming candidates for clinical trials. And probably for the new drugs, the disease-modifying treatment, this group will be. So we have to get good at diagnosing amnestic mild cognitive impairment because these will be the group of people who will benefit most of the newer treatments. So how do we change the Alzheimer's disease diagnosis? And with a lot of research going on, it's becoming more of a clinical biological entity using biomarkers. So before it was clinical pathological, you had clinical symptoms and you had the pathology after death. Now with the biomarkers, it becomes clinical biological. You have the clinical symptoms and you can use these biomarkers to increase your diagnostic certainty. Unfortunately, we are learning that it's still not the absolute test, but it really improves your diagnostic certainty. So for the clinical biological definition, you need the phenotype, which is the memory problem, cognitive decline, And you can use biomarkers, which could be pathophysiological or topographical. Pathophysiological look at the amyloid beta cascade, amyloid and neurodegeneration, tau. Topographical markers look at where Alzheimer's disease usually starts, in the temporal cortex, hippocampus, and the parietal cortex. So for pathophysiological biomarkers, we have CSF, amyloid beta 42, total tau, and phosphotau. And we have the amyloid PET, which is now available in Buffalo. For the topographical biomarkers, we have the regular glucose PET, which is going to just light up where the problem is in the brain, and medial temporal atrophy, which includes the hippocampus and the temporal lobe. Now, these biomarkers uncouple the diagnosis from the severity, because before you had to have the full-blown Alzheimer's with 2 domains at least affected. Now you can have prodromal AD diagnosis if somebody has amnestic mild impairment and one of the biomarkers positive. So we are shifting the diagnosis earlier, so we can shift the intervention earlier, so we can keep people in good shape for longer periods of time. So really, what happens in the brain, this is I think a very striking image. So this is when these are derived images. This is structural MRI. So they took 100 people with single domain mild cognitive impairment who had only a memory impairment. When your patient comes in and says, I have memory problems, that's the group. Their MMSE is normal, usually. Maybe 1 or 2 points lost. And then they took 100 normal controls, same age people who are fine. And they were neuropsychologically tested normal. So really, they have nothing wrong with them. And then they subtracted the volume of the normal people from the MCI people. And the red is when there's a difference, and the yellow when there's a huge difference of volume. Now, volume in neurodegeneration correlates with neuronal loss, neurodegeneration, a not reversible phenomenon. So at the time when your patient is complaining of, I have memory problems, and you can't really measure it yet, they might repeat themselves occasionally, they already have significant atrophy in the temporal lobes. If you take multi-domain mild cognitive impairment, they start to decline a little bit in other domains, but they are still walkie-talkies, driving, taking care of themselves, living alone. MMSE is probably between 25 and 30. Those people have this extensive atrophy of the brain, extending to most parts of the brain, except probably the occipital cortex that's preserved. And you see that in the temporal lobe, in the mesial temporal lobe, the atrophy is really prominent. And then they get into the stage of mild AD, and these are people with MMSE between 20 and 26. This is the difference that you see. So intervention at this stage is probably too late. You have to shift it earlier, and that's why we have to get good at diagnosing amnestic mild cognitive impairment. Now, what do we see with the other biomarkers? These are PET images. So this is the glucose PET, this is the amyloid PET, this is a normal person, and this is a person with Alzheimer's. So the glucose metabolism is lighting up in the normal person in the parietal lobe, very nice and red, very active. At the same place, in the Alzheimer brain, it's not lighting up. And then there's no amyloid deposition here, and there's amyloid deposition all over the brain. And this area here with the marked amyloid deposition is actually correlating with the decreased metabolism. So this is how PET can help you. And then you always have to keep in mind atypical Alzheimer's disease. And that's when the episodic memory deficit is absent. So it can be primary progressive non-fluent aphasia. For the differential, it's frontotemporal dementia, frontotemporal lobar degeneration. You can have logopenic aphasia in Alzheimer's, differential diagnosis to frontotemporal dementia. Posterior cortical atrophy, when it's really a perception, visual perception that's impaired. They are legally blind. They see, but they look, but they don't see. So for example, they are cooking, and the husband says, can you pass me the salt shaker? And the woman is looking, and there are 6 things on the counter, and she cannot see which one is the salt shaker. That would be a presentation of posterior cortical atrophy. Frontal variant of Alzheimer's disease, and it comes with a lot of behavioral issues. that can happen as well. These will be tricky, and probably it's going to be a challenge for anybody to make this diagnosis. You have to have longitudinal observation, you have to have suspicion, and then you probably have you need some kind of pathophysiological biomarker to fully differentiate between the two.